Good afternoon, everyone. We're going to go ahead and get started. My name is Rosalyn Park, and I'm the director of the Women's Human Rights Program at the Advocates for Human Rights. I want to welcome everyone to this webinar, Gender, Human Rights, and COVID-19. And I'd like to thank the University of Minnesota Human Rights Lab and the Center for Global Health and Social Responsibility for organizing this important webinar in the context of a bigger series, Envisioning the Future, Advancing Human Rights in a Time of Crisis. Today, we have an esteemed panel of experts who have been investigating the pandemic as it relates to employment, sexual and domestic violence, and the needs of transgender and non-conforming persons during the COVID-19 crisis. Since the emergence of the pandemic, we have all seen its devastating impacts on health, communities, economies, societies, and schools. And as we all know, economic crises tend to impact women more heavily, as women tend to have lower incomes. They are often more found in informal economies, unpaid care, and domestic work. They tend to be more represented in single-parent households, and they have less access to social protections. There is no exception to this rule under the pandemic. And indeed, women are shouldering the heaviest burdens of the socioeconomic fallout of COVID-19. On top of the unemployment impacts, we are also seeing enormous problems with sexual and domestic violence. As stay-at-home orders went into effect, access to information about assistance narrowed, and safe places to escape or report abuse all decreased, all of these factors exacerbated violence against women. And as with other marginalized groups, trans and gender nonconforming persons also face unique challenges. For example, partners in other countries describe to us how sex-specific curfews exposes trans persons to threats and physical harm by both authorities and private actors who persecute them. These urgent issues will be addressed by our panelists today, and I hope you will contribute with your own questions at the end if there is time. It is an honor to introduce our speakers today. Our panel includes Dr. Christina Ewig, Professor and Faculty Director of the Center on Women, Gender, and Public Policy, Dr. Ruby H. N. Nguyen, Associate Professor in the Division of Epidemiology and Community Health, and Dr. Katie Spencer, Assistant Professor, Department of Family Medicine and Community Health. So I would like to begin by directing my first question, which is a two-part question, to Dr. Ewig. Dr. Ewig, the research on gender and work in the pandemic analyzed patterns of gender, race, and industry in relation to unemployment. I'm wondering, what did you find in terms of the hardest hit groups? And also, are existing gender inequalities in domestic care responsibilities exacerbated by the crisis?
Thanks, Rosalyn. It's great to be here for this important topic. When the pandemic first started, I had two primary concerns. One was we could see a lack of personal protective equipment for workers on the front lines in the healthcare sector in particular in combating the virus. And these workers we know, are primarily women. And on the other hand, we began to see pretty quickly unemployment figures coming out in which, to somewhat of a surprise, but not if you begin to think about the different sectors that were closed by and impacted by the virus, we saw more women filing unemployment claims. So this summer, I put together a research team with two fantastic students, Matthew Bombach from the Applied Economics Department and Amy Dorman from the Humphrey School. And we began to look at what really the impacts on employment have been in Minnesota by gender and also breaking down by race and ethnic groups. I'm going to pull up one slide that gives you a sense of the gender breakdown. And so here you can see that if we just look at the COVID-19 crisis, we know that it impacted different parts of the labor force in different ways. And one of the ways in which it impacted it was of course, those that were laid off as a result of closures of a number of sectors, retail being one big sector, entertainment, arts, food services. Then, of course, there were those workers that were working, that continued to work, but they were working in high risk categories. So, for example, those, of course, that are working from the in the healthcare sector, but also grocery workers, those that had regular public interactions that then put them in a high risk position. Bus drivers would be another group in there. And there's another group which are essential low risk. So actually in the state of Minnesota, we saw 78% of workers continue to work. They were declared essential in some way. So areas like manufacturing and construction were considered essential, but didn't have a lot of person-to-person interaction or were outdoors, as in the case of construction, and so were lower risk areas. And finally, we know lots of people transitioned to working from home, including school teachers who initially, if we look at data prior to COVID, would have answered that they couldn't work from home, right? To be a job in which they needed to be facing their students, but we saw a movement to online. So what we did in this study is we looked at these, we broke down Minnesota workers into these 4 basic categories and began to look at the demographics. In this graph, this is just based upon sort of a rather crude division according to those industries that I just mentioned and more, but that would fall into these 4 categories. And so we estimated based upon this that we would see women having really a dual vulnerability. And this plays out in the rest of our data as well. One, they are more vulnerable to layoffs or they are more likely than men to be in the essential high risk workforce. So in terms of that essential high risk workforce, this is again, grocery store workers, healthcare workers. When we look at it by race and ethnicity, it's principally women of color that are predominantly in these essential high risk positions. We see upwards of 30% for Somali women of those that are within the workforce working in this high risk category. Asian women of all the major Asian subgroups in Minnesota, and white women, as well as Native American women. So, but the biggest concentrations in terms of women of color are Native American, Asian, and Somali. When we look, and I'll get to layoffs in a bit, but we also see a concentration, but a different group of Native Americans and African Americans. And again, principally women vulnerable to layoffs. By contrast, those that are likely to work from home end up being fairly similar between men and women. We don't see a huge gender distinction there. What's most important if you're going to be able to work from home is having a college education. These are the kinds of positions that allow people to transition to work from home. And we see more in terms of race and ethnic groups, Asians and whites in that category. And men on the whole, because their work is more concentrated, either in those positions that are able to transition to work from home or in areas like manufacturing or construction, we see them predominantly in that essential low risk category. So able to keep their jobs without a whole lot of change. Now the vulnerability, so when we think about gender in this, we see a dual vulnerability for women, especially women of color. First in that essential high risk category, but also in vulnerability to layoffs. So when we look at the layoffs, here we're using data from the state. So the unemployment claims, the actual claims that were made, and here we divide it by Native American, Black, Latino, and Asian, and white, which are the categories that the state uses. And here we also see with the orange bars on the right-hand side that in every case except African Americans, women outpace men in terms of actually applying for unemployment insurance. So we see more women being laid off overall, which has a lot to do with the sectors in which women are concentrated, such as arts, entertainment, food services, areas in which we saw greater numbers of closures. I think when we looked at this data, the surprising piece for us was that when we had anticipated, without actually seeing the unemployment claims, but thinking just about the industries in which different demographic groups tend to be employed in Minnesota, we did not expect Black men to have the high layoff rates that we see. So men and women, African Americans, both have had a 22% rate of unemployment in this period. And so this was something that we've tried to look at further as to whether or not industry or occupation explains this, and whether or not this explains the higher rates of women overall. And in doing some greater analysis into the numbers, we find that industry and occupation only represent a small fraction of explaining why we see both higher rates of layoffs for women and both higher rates of layoffs for African Americans compared to whites. It gives us some of the explanation. In the case for women, about 15% is explained by that industry and occupation category. I'm sorry, by occupation, but industry doesn't explain it at all. Whereas for African Americans, we see some industry and some occupation giving us some leverage, but the vast majority of the reasoning is unexplained. So there could be a number of reasons. We could use more detailed data to get at why we're seeing these discrepancies outside of simply where people are working. Discrimination is probably one piece of what's going on. Could also be in terms of women. Women tend to work part-time more often, and it could be that those that are working part-time are being let go more quickly. So there's a number of different things that still need to be investigated to really understand why we see these discrepancies in terms of layoffs. So finally, in terms of, Rosalyn, you asked about childcare support and domestic responsibilities. And in this instance, we had hoped to gather data on and exactly find out. This was a perfect natural experiment to see what happens when kids are sent home from childcare centers and from schools. What would happen in terms of childcare, which among fully employed working adults in Minnesota with children under 6, women do more of the child care, but there's not a huge discrepancy between fully employed working women and working men. The question is, when kids are sent home, would we see a change? Would there be less equality among these full-time workers? And we weren't able to measure that. Our best source of measuring that is the American Time Use Survey. And that was put on hiatus during the COVID shutdown. So that experiment was not able to be done, but we did do interviews with 19 different combination of community service organizations and unions, leaders of unions, and asked them what were some of the issues that their workers were facing and what supports were the most important for them. And one of the big stress inducing aspects was the lack of childcare and real challenges in terms of balancing the ability to continue to work if these were essential workers in particular, or work from home if they continue to work from home, and also take care of children at the same time. But we don't know whether this changed in terms of the gender dynamic within heterosexual households of who would be doing more of the childcare work. And it could be the person who is laid off. And here we see the numbers as primarily women. That would make the most sense, that in those households that women would be doing more of the childcare in those cases. I'm sure that flexibility always plays a role in terms of job flexibility, in terms of who ends up doing the lion's share of work within the home. So those were some of, that's a peek at some of our findings for a report on COVID-19 gender and the workforce in Minnesota that we hope to be releasing later in October.
Thank you so much, Dr. Ewig. We all know that women tend to shoulder double burdens, double workloads, and here you've introduced us through your intense research over the summer to the dual vulnerabilities that women will face due to their exposure to more layoffs and working in essential high-risk workforces. So thank you so much for illustrating the intersectionality and the vulnerabilities that women will face in the employment sector. So next, I want to turn to Dr. Nguyen. My second question focuses on her research, which is on sexual and domestic violence in the pandemic. Your research looked at how organizations that work to prevent violence or directly help survivors through services like emergency hotlines, women's shelters, and access to legal advocacy, and how they are faring in this time of crisis. Dr. Nguyen, can you share with us what you have learned?
Absolutely, Rose. That's a great question. I just happen to have a slide set on it. I'm joking, of course. Welcome to my office and my home and the area where we do 5th grade art projects. So I wish we were all in person, but as you know, we are all living through some crazy times. And that's really what we're starting to see as an emerging theme for our ongoing work here. I'd like to first acknowledge my primary community partner who, without this work, it couldn't be done. And that is Violence Free Minnesota, formerly known as the Minnesota Coalition for Battered Women. So if there's anything I want you to walk away with after my 12 minutes, it's this. We have to acknowledge how violence against women is changing during this pandemic. And we have to acknowledge how that change is affecting the direct service providers. And without doing that, we can't successfully address the victims' and survivors' needs at this time. And so what I'll do in the next 12 minutes is really lay out to you what differences we've been seeing compared to what we expected to see. So what do we know about violence against women in epidemics? Well, interestingly, globally, we know a lot. We do, in general, know that violence is perpetrated against a woman essentially every 12 minutes, a woman dies from violence. But intimate partner violence is the most common form. Over a woman's lifetime globally, 1 in 3 women will experience either sexual and/or physical violence. And we know, and we've known this for a long time, that violence against women increases during instability. So whether that be war, political instability, or epidemics, and in this case, a pandemic. So let me minimize. Why is it that health crises such as epidemics, why would they increase violence? Well, we know that not only the effects of the epidemic itself, but the subsequent infection control measures such as isolation influence rates of violence. What are the roots? Well, stress is a primary root. Stress from all different sources. As we know from this in the United States currently, there's great individual and family level financial stress. There's stress of child rearing, particularly with stay-at-home orders in which the children have been sent home. There's stress with inability to obtain routine medical care. And with all of this put together, we know that for the individual themselves or for their partner, substance use may increase. In addition, a separate mechanism may be through the disruption of existing networks. It could be a social network, such as isolation removes you from your friends and family who would normally support you during these times, or from another network. Let's just call it a protective network, a network in which you would normally go to if violence occurs. And that might be, for example, direct service providers, health providers. And I also already briefly spoke about perhaps an inability to seek routine health care. And then lastly, protective measures might be influenced by our collective trauma. So that's going to be a theme that we see at the end of this too, which is simply that individuals providing service and care to victims are also going through this pandemic themselves and also share the same list of stressors that the victim survivors are facing. So what we really sought to do is to look at the pandemic effects specifically for the state of Minnesota. Look, we knew a lot was going on, but in Minnesota, we don't routinely see political instability. We don't see large health crises like we're seeing. So we wondered if Minnesota and our residents would have similar experiences to what we're seeing globally. And to be very specific, we, at least for this presentation, we looked only at this period of time in which the governor had evoked a stay-at-home order. So what was that stay-at-home order? In the state of Minnesota, it was to direct Minnesotans to limit movement outside of their homes beyond essential needs. And that was with the intention of reducing transmission. The dates for the Minnesota stay-at-home order, which was extended, but in finality, it was March 27th through May 18th, so roughly a 9-week period of time. And then immediately following the stay-at-home order was a more opened order in which is called the Stay Safe order. And so restaurants and bars and the such started opening after May 18th. So in Minnesota, it was communicated that Minnesotans may leave their homes during the stay-at-home period to pick up essential items, and they listed what those essential items might be. In addition, Minnesotans might leave to get prescriptions, gas, relocate for safety reasons, which I've highlighted, or go to work if their job was deemed essential. And Christina had spoken about that already. In addition, in this stay-at-home order, it was very specifically stated in the long verbiage of the order itself that if Minnesotans felt unsafe in their home, they could leave. So the verbiage from the order itself read, if you feel unsafe in your home, you should leave. If you are in an emergency, call 911. So given that the stay-at-home order said, if you don't feel safe, call 911, given that direction, did we see in Minnesota an increase in 911 calls related to domestic violence, which would be one indication to us that indeed rates of domestic violence were heightened during this period of time? So what we did is we looked at local law enforcement domestic violence related 911 calls, as well as domestic violence related calls that didn't necessarily go through the 911 system. In the States and in Minnesota, local law enforcement hold their own data. So we went to as many as we could. And we also noted when it was 911 data that was being reported versus all DV calls. And this is what we saw. So I just pulled out 4 examples for you. On the left-hand side, you're looking at domestic violence calls to the St. Paul Police Department during only the stay-at-home period. So roughly the end of March to middle of May. And the reason you see 2 separate dates there is depending on what calendar year it was, 2019 or 2020, the dates slightly differed, not substantially, but we've listed those. The blue or the left-hand bar indicates the year 2019, and the orange on the right-hand side indicates 2020. So when we're looking at the St. Paul Police Department data, and these are all domestic violence-related calls, meaning 911 dispatches as well as calls to the precincts themselves, we see that for every week of the 9-week stay-at-home order, there was an increase in the number of DV calls to St. Paul. You see that? So every week there's a higher orange bar, and substantially in some weeks. When we look at Minneapolis, for those of you who are not local, the largest city in Minnesota is Minneapolis, and I believe it's got a population of 400,000. When looking at the Minneapolis 911 domestic violence related phone calls, we see that in all but one of the 9 weeks, there was an increase in 2020 versus 2019. Not as substantially as observed in St. Paul, but an increase nonetheless. When looking at county level data, meaning sheriff's level data in surrounding counties in the metropolitan area, on the left-hand side, we're looking at Anoka County, and on the right-hand side, Dakota County. We see, stories that are consistent with what we saw in the two most populous cities in Minnesota. For example, for Anoka County, for the sheriff's office, we do see in all but 1 week an increase in 2020 reports compared to 2019. And then for Dakota County, either very similar data or for the month of May, an increase, a marked increase in DV-related calls. Again, the differences in data are because of the differences in the way the law enforcement units report. So if that's the case, if we are actually seeing more DV calls, wouldn't we expect that the direct service providers, the shelters, the hotlines, would be seeing more traffic as well? Well, interestingly, when we looked at data from the statewide crisis hotline, which is called Day One, we observed kind of something all over the place. So when we looked at their reports of contacts for any particular week during the stay-at-home period, we observed that for the first 4 weeks, there was in fact an increase in the number of contacts. And contacts for Day One include the following: phone calls, emails, even text messages. So weeks 1 through 4, we saw an increase, but essentially weeks 5 through 9, we saw decreases compared to 2019. So substantially fewer contacts in 2019. So when we're looking at weeks 8 and 9, we see roughly 150, somewhere between 150 and 100 less contacts in 2020 than we see in 2019. So that was quite puzzling. We had hypothesized that we would see, for example, a much higher or more consistently higher contact number than this. And we didn't expect to see a reduction in contacts. 1 second. So then we use data. Then we use data from a survey that was administered by Violence Free Minnesota, looking at each of their direct service providers located throughout the state. So 84 direct service providers provided a response here, and consistent with the Day One results, approximately half of them, 54%, indicated that there was a reduction in the number of contacts that they had during this period of time. A reduction. So if you look at this, there's a slight decrease and a large decrease category for respectively, and totaling those, that's 54% of their agencies saw some type of decrease during this period of time, whereas 15%, about 15% found that the call volume was essentially the same compared to prior to the pandemic. So that was also curious to us. Again, not consistent with the 911 data. We had some data from the court system in Minnesota as well. There's a lot of caveats with this data in the sense that the courts were reduced in their capacity. They changed filing systems, for example. For a while, they were not accepting any paper filing, but electronic only. So this is what we see. This is data directly from them, the Minnesota Judicial Branch. So we see that in the beginning of the lockdown, of course, we see a reduction because the courts are more limited. But as the stay-at-home order proceeded on, we saw, and the court started seeing more cases as usual, things started to increase again. And if we were to extend this timeline out until September, we do see that the number of court filings is very consistent, if not above that of what we saw for 2019. So these are for orders of protection and harassment restraining orders. So what could possibly explain the differences in really high 911 call rates versus lower contacts with the direct service providers? Well, when we convened a group of direct service providers, they gave us a few different suggestions. And these are examples of how during this pandemic, there is this evolution in how domestic violence may be changing for us in Minnesota. So what we did was we asked them what could explain this reduction in the number of contacts to the direct service providers themselves during the stay-at-home order compared to, for example, the high 911 call rate. The first thing that they thought of was initially there was poor communication across the state about whether the direct service providers were even open. So on the left-hand side, you see a flyer that was put out by the state of Minnesota, and it lists very cleanly things that are open and things that are closed. What we did not see listed there was the essential nature of the direct service providers. So what Violence Free Minnesota was, within days of seeing the original release, they modified it and widely distributed it to add domestic and sexual violence programs were in fact open. So again, one of the top reasons they think that there was potentially a reduction in contacts was simply people didn't know who was open. And maybe that was associated with a higher call volume to day one, the statewide hotline. Other reasons that could explain this difference included perhaps we're seeing more severe incidents that would elicit calls to law enforcement. So we have some evidence, although I was wary to provide it because some of it's ecological, evidence that there is increased weapon use. And ecologically, we know that gun sales in the state of Minnesota, as well as nationwide, are up during the pandemic. So maybe 911 is getting a lot of calls because of how violent the incidents have become. The third reason that they thought of is perhaps there's a reduced or a complete inability for women to consider long-term planning, which is one of the functions of direct service providers. And long-term planning, for example, would include a plan to exit the home. And so what the direct service providers were suggesting was the reason for this, the women had little time in the absence of the abuser. So they're in the house together. They reported that it wasn't uncommon for a woman to seek shelter literally in a closet in order to speak to the direct service provider just for a few minutes. Secondly, additional financial constraints. We know that finances are always a huge problem when considering leaving a violent home, but during the pandemic, those were worsened. There was instability in the children's schooling. So for example, sometimes women can rely on children being at school for large periods of time in order for her to plan an exit or for her to plan her next location. But unfortunately, especially during the stay-at-home period, she was unable to do so. And then lastly, there was a collective trauma, and to all of us, including our social networks. So women were reporting, well, I would usually go to my sister's house, but things are crazy there as well. So social networks were disrupted simply because of the collective trauma. But despite the fact that direct service agencies may have been seeing a reduced call volume, so the numbers, I'm an epidemiologist, I generally rely on numbers, but I was very much swayed by these qualitative data. So despite the fact that they might be seeing, or they might have during the stay-at-home order have seen fewer numbers of calls, they really felt that they were in a fragile state anyways. We know that. These people are superhuman. They do an incredible amount of work with very few resources in a short period of time. And the pandemic and the stay-at-home order still stressed that despite having fewer calls. So for example, the reasons for that included, they believed that every client took more time. So if a woman needed, for example, to apply for a harassment restraining order, an HRO, They couldn't do it they couldn't do it on paper, which is what they were accustomed to doing. They had to do it electronically. They had to sit with a woman in a safe space and complete it electronically, which took more time. They found that they had problems with their own staff, in the sense that, again, staff are becoming ill. They have ill family members. They needed to quarantine. All of these different types of things that were occurring in the community clearly also affected the small staffs of the direct service providers. And this was true. They made a clear case for this, that it was true for not only their paid staff, but also their volunteer staff. There was an example in which they were relying on university-based volunteers as advocates, for example. And when the universities made the decision to pull all of their students from field experiences for safety reasons, that organization lost that catchment of volunteer staff.
So Dr. Nguyen, I'm so sorry to break in here. I'm just wondering, in the interest of time, this is such fascinating information, but if it'd be possible to just wrap up in the next minute or so?
Absolutely, this is it.
Okay,
Thank you,
fantastic.
Rose.
Thank you.
Thank you. So in addition, shelters were unable to get outside assistance. And this had really a geographic spread. So for example, counseling services that perhaps we take for granted because we're on the internet right now, wouldn't be possible in remote shelters that didn't have routine internet service. Their geographic and cultural needs are specific to agencies in Minnesota. And then and then finally, they're seeing large bounce back numbers now. So we primarily spoken about the stay-at-home order, that 9-week period, but since then, the numbers have increased to levels above that seen at the beginning of the pandemic. So lots going on, regardless of whether the initial reports were that they were seeing fewer clients. So thank you to the entire team who's worked diligently on this. Sorry, Rose, that's it.
Thank you so much, Dr. Nguyen. That was such a tremendous amount of information, and we're really grateful you could provide us with a snapshot of all of the research you've undertaken during the pandemic. So for our third and final speaker, I'd like to turn to Dr. Spencer for our last topic. Dr. Spencer, what are your concerns and suggestions for addressing the medical and social needs of transgender and gender nonconforming adolescents and adults during this health crisis?
Hi, thank you all. And I will try to stick a little bit to the time so that we have time for questions at the end, just to like sort of compensate, but I will go a little bit into some of our question time. Yeah, my name is Katie Spencer. I use she, her pronouns. I am a psychologist and a sex therapist and a gender specialist, and I work at the Program in Human Sexuality, which is a program of the medical school, the University of Minnesota Medical School, and the Department of Family Medicine and Community Health. I am also the newly minted co-medical director for comprehensive gender care for mHealth. And so I'm here to talk a little bit about some of the clinical and practical implications, the impact of COVID on transgender and gender diverse communities. So I have a few things that I just want to talk about that we've seen in our practice here. But I wanted to just contextually acknowledge, I've been doing this work since about 2007. And so a lot has changed in transgender healthcare since 2007, and especially like over the last 5 to 10 years or so. And we've had a lot of advancements in the state of Minnesota around protections like legal and policy and insurance coverage for transgender and gender diverse patients and communities as a whole. But I wanted to also acknowledge, and I'm going to be speaking specifically about the US context, and I'm talking about in Minnesota, that we cannot extrapolate that out to the whole of like trans communities like globally. I've also done some international policy work with trans and gender diverse communities, and it looks really different from country to country, and there are a lot of contextual factors that impact people's experience. And so I want us to really hold that and to think about like what that looks like in Minnesota. So the impact of the pandemic in Minnesota, we also can't extrapolate out from what's happening like in our region. So what I've seen in practice is not only about the pandemic, but about the uprisings, about the murder of George Floyd, about systemic racism, and also the impact of like late stage capitalism on the medical industrial complex. And so I think that I can't separate out all of those things from what the impacts are. It's not just like a pandemic and a health crisis, but we're in a crisis on a larger scale around getting to a point where healthcare is unsustainable, and trans and gender diverse communities are experiencing sort of the brunt of that. And from an intersectional framework, it's Black and Brown communities that are at the forefront of that. So I think sometimes when I'm asked to speak about like trans and gender diverse healthcare, um, white trans and gender diverse people and people who are middle and upper class have a very different experience than Black and Brown folks and people who are poor. Um, so hold that in mind, thinking about like what we've seen. Some of the challenges have been like you all have probably experienced this in your own healthcare. Most everything has moved to telemedicine, but telemedicine requires resources. So you have to have access to an internet connection. You need to have either a phone or a laptop, and a lot of the telemedicine platforms don't have a lot of technical problems, and so people have a hard time connecting. It's hard to like get access in the way. So it's created more barriers in those ways. And I don't think that, I'm just speaking for mHealth Fairview, the problem solving about that has not been as robust as it needs to be. So that is an issue. Another thing is that surgeries have been, at first they were just completely canceled. So in my practice, a lot of people who were scheduled for gender affirming surgeries such as vaginoplasty or phalloplasty or chest reconstruction, things that people have been planning for and working for years to make happen in their lives, were just canceled without any sort of guarantee about like when that would happen. And that can really bump up people's gender dysphoria. It bumps up their depression and anxiety on top of the depression and anxiety that's already happening in this like kind of meta trauma environment of the pandemic and everything that's happening. So now they're starting to put in more surgeries, but gender affirming surgeries are considered elective within the sort of how they triage surgery within the medical language. And so they don't get as much time in the OR. And so then we're still backlogged by months and months. And so people who were scheduled maybe to have surgery in like July are now being told they'll have to wait a year or two for this surgery that is really medically necessary for them and life-changing. Another thing that I've really seen in with gender and gender diverse and trans communities is that the escalation in divisive rhetoric and the political climate, because I think trans communities are used as like a wedge issue, are sort of used as a target that's escalated violence, and it's made people feel unsafe, and it's made people feel unsteady in some of their protections. So we've only had health insurance coverage for gender affirming surgeries in Minnesota. Oh gosh, when did we get that? Like 5 years ago. And so before that, there was not a mandate, like insurance companies could make a decision if they wanted to cover it or not. And that really, I think the unsteadiness around that, people don't trust that there are legal protections or employment protections because of the divisive and violent rhetoric that is so pervasive in our culture. Another aspect of that, I think, in my experience working within a medical system, is that a lot of efforts that have been made around legal and policy changes have been made in a reform aspect rather than a radical aspect. And so some of those reforms, like health insurance is a really good example. I was part of the task force that helped get those protections. But now what we've seen subsequently is that insurance companies have added more requirements, more hoops. They deny more coverage, which means it creates more barriers, which actually then can escalate negative health outcomes because it's so anxiety provoking and depressing to have to fight with your insurance company for something that is medically necessary that you need for your care. So I would argue, if we're going to talk about suggestions on how to address things, is that we need socialized medicine. We need to dismantle the medical industrial complex. And I say that and I kind of laugh, but I wholeheartedly mean it. As someone who works in healthcare administration, it's about capitalism, about money. It's not about people's well-being, and that is fundamentally immoral and unethical. And so if we really are going to talk about human rights, we have to center that framework in order to create that kind of change. Another part of that is that if we're just talking about in practice, there's not enough training. People don't know enough actually about trans healthcare. They think sort of if they've learned some terminology and like learned about pronouns, that that's enough, but that's not enough. And that trans and gender diverse people experience a lot of stigma, discrimination, and not competent care, which exacerbates negative health outcomes. And then just on a policy level, like, and a larger level, we need to expand our language and how we think about gender, and that we need to center the most marginalized in order to improve outcomes for everyone. And so often I experience, like, I'm in spaces where we're talking about gender in this binary way, but I think that obscures misogyny and hatred of femininity, and femininity is embodied in lots of different gendered bodies. And so it flattens and erases the experience of so many people. And so one of my suggestions would be like something that we can all do in our day-to-day life is to be more thoughtful about language, to unpack how we think about gender and be inclusive of trans and gender diverse people and perspectives. And we need to stop having white cis women like me talking about trans communities and actually have trans people talking about their experiences. So those are all the things that I would suggest. I hope that that's helpful. I kind of went through that quickly. I definitely have more I could say, but I really want to make sure we have time for all of the wonderful content that's been presented today for questions. So thank you.
Thank you so much, Dr. Spencer, and for illustrating the different challenges and also sharing some of your recommendations for how you can see things shift in a positive way coming out of this. I don't see any questions coming in from the audience yet, but I do encourage you to use the Q&A function if you would like to ask some specific questions. While we're waiting, I have one or two questions I'd like to pose to the panel. And my first question is, with some exceptions, women are underrepresented at the very highest levels of decision-making around the pandemic. So how might greater participation of women, especially women of color, at high levels of policy making and implementation change the trajectory of this pandemic? And I'll put it out to any of you who wants to jump in and answer this question.
I'll jump in. So I think one of the findings that we had in our research, we looked at what kinds of supports were workers that were either laid off or experiencing high risk on the job. What were they looking for? And what's interesting is that although, of course, there's always some instances of confusion or difficulty accessing, for example, the unemployment insurance or the stimulus checks, by and large, those two kinds of supports went fairly smoothly for people, according to the community leaders that we spoke with. Lack of personal protective equipment, on the other hand, was huge and a big concern, something where unions were out doing their own drives in order to get that equipment for their healthcare workers, for example. And as I said before, the childcare supports were completely missing from the picture. So what's interesting when we looked at the supports was that those things that had to do with safety and care, seemed to be completely overlooked, and those things that had to do with helping people out in terms of their income, but also which had an important role in keeping our economy rolling. And that's not to denigrate that aspect, but that was what worked well and was prioritized. So what would happen if we had women at the table, women of color at the table? What would happen if we had more gender diverse individuals at the table, to bring in Katie's point? I do think that brings different experiences. Women don't innately come to the table with interests in childcare, but women often have more experience of having to have had the responsibility for childcare compared to men. It's not universal, but that bringing that experience to the table in these discussions, I think may have made a difference in terms of our attention to, for example, how can we open schools safely, which ultimately has these universal impacts in terms of helping our economy, helping the future of our kids. But I do think, and that was something that came out of our interviews as well. One of our interviewees said very pointedly, we need women at the table. We need Black women at the table who are most impacted. From her perspective, she worked primarily with African Americans in the Twin Cities area in order to make better policy.
For domestic violence policy, when there are not women who are involved in the policy making, it's an important indicator to me that the policymakers are not concentrating on the vast expertise out there, given that the overwhelming number of people working in this area are women.
Thank you, Dr. Ewig and Dr. Nguyen. We have a few audience questions rolling in, and so I want to try to get to these. And this is actually my next question too. This question is to Dr. Spencer. The audience member appreciates your approach to the topic and would like to know what are policy changes you'd like to see at the state or federal level to make these changes? And do you have some examples from other countries?
Let's see, do I have any state or federal? I mean, one thing, I guess the example that comes to mind that is most pressing right now is that every year legislators target our program in particular and other clinics that provide puberty suppression for trans and gender diverse youth, and we have to justify our treatment protocols. And, you know, there's this sort of like frenzy worked up about how we're making children trans or something. So there's a lot of misinformation. I would really like it if there was some protections around that, and so that every year we didn't have to like make that fight, and that our funding wasn't threatened through the university. I mean, it's through the funding through the university because we're a part of the University of Minnesota. So I guess maybe having legislators and people like collaborate with activists and organizers in trans and gender diverse communities to create protective legislation that is forward thinking rather than reactive would be one part of it. Another part of it is kind of just what I said. I think there is like a personal, it's individual and collective in our work and how we think about gender as a construct, and then how we talk about that, how we do research around it, how all of the different aspects of that. And so we really need to make some changes on that. And do I have examples from other countries? I mean, one of the things that I'm part of the World Professional Association for Transgender Health, WPATH, which is the large international organization that develops the standards of care for clinical considerations for trans and gender diverse communities. And it really varies by country. And so one of the things like in European countries that have socialized medicine is that it creates this sort of tiered aspect of care, and it tends to reinforce actually more binaries around that. So again, it brings us back to sort of a radical transformation about how we think about gender binaries and how that's related to patriarchy and capitalism and like these interlocking structures. So I know that, again, that's not very practical, maybe in a sense. And in other countries, I don't know if they've thought about that as much, but I do know that in some of the organizations and in countries of policy where were invited in and had key stakeholders and given power, actual power, not just sort of what's the word that I'm looking for? Like having someone who's just sitting there who doesn't actually get to have a voice or have agency, but actual power to people to make those decisions. That's what's necessary and what's needed.
Thank you so much, Dr. Spencer. I think we have time for one more question. My apologies to the audience, but I hope that you can reach out to people afterward if you'd like your questions answered. In the last 4 minutes of our panel, the question is, as we think about gender rather than women as gender, can the panel reflect on the gendered consequences of the pandemic on men and boys? And I'll open it up to whoever would like to take on that question.
I can say a little bit about it, not in relationship to employment. I mean, I think I've shown that men on the whole across racial groups were in low risk work or less likely to be laid off than women were. But that's not to say that some of course were in high risk work and some of course were laid off. But I've written separately about the impact of the virus itself has had a gendered impact, and where we've seen, at least globally, more men than women dying of the virus. So contraction rates are similar across women and men, but more men dying. And part of that could be biological. There is some research into whether or not the additional X chromosome that women have may protect them from the virus to a greater degree than men. But I think some of it has also to do with gendered practices and assumptions in which we have ideas about masculinity in many societies, including US society, of a certain strength and invulnerability to sickness that then leads to actions that take less care in terms of personal care, whether it's wearing a mask or washing one's hands. And I also think that the employment aspects can also have stronger psychological impacts on men when society places high expectations for playing a breadwinner role, a traditional breadwinner role. And if they cannot do that, that can lead to high stress situations. So I think there's a number of different ways in which masculinity and our expectations of men and boys means that they have been adversely affected in terms of their mental health and their physical health in this pandemic.
Thank you so much, Dr. Ewig. Dr. Nguyen, did you want to add something?
I did, please. So I spoke primarily of violence against women and domestic violence. I appreciate this question very much, in fact. But what I'm really getting at is family violence. So this is violence within the home in which little boys see as well. So boys are affected. I primarily spoke about physical violence, but we also know that these isolation patterns promote predators for sexual violence as well. And without doubt, boys are affected by sexual violence. So many of these overlapping themes have drastic impacts on boys in these families and households as well. With regards to men, I just wanted to agree with Christina on the point that when we think about stressors to family violence, we think about men's mental health, men's substance abuse, and of course, those are being neglected during the pandemic as well, unfortunately.
Great. Well, thank you so much. This actually brings us to the close of the hour. I want to thank all of our panelists for their substantive and very informative information and expertise they shared with us today. We've all learned so much about the multidimensional facets of COVID-19 and its impact on the implications of gender. So thank you again. And so I wish you all the best for the rest of the day. And we hope you'll see you at the next in this series put on by the University of Minnesota. Thank you again.